I really want to thank everyone for joining us on this day one of our CIDCI Fall Forum. I think hopefully everyone knows we are running a forum every day at different sessions every day for 90 minutes. So my name is Stuart Ekblad, and I'm chair of CIDCI. I think, and just to remind people, CIDCI's mission is to accelerate change, adoption of new and better ideas for the built environment. Our goal is to convene innovators, individuals, firms, educators, industry, those with a passion to improve our industry, to make a change, to make a difference. We also want to be and are a trusted source of information about innovation, what's going on, what's happening, and what, as these firms and these individuals start to have new and better ideas, how do that information come to CIDCI, and how do we transmit that information to you? We want to thank you for being a part of our community. That's how we think of ourselves, as a community of innovators. So what's been happening? So in this pandemic, I think we've all had to face a lot of changes, but we are very proud that we have made significant changes. Since March, we've hosted 13 webinars, all of course online. Most of those are in fact recorded and available on our website. We've also hosted an innovation lab of emerging leaders, about approximately 35 people from firms who came together and to work on ideas about and from themselves and for their companies to think about challenges in business, particularly with COVID-19. We also have an Innovation Leaders Roundtable, and this continues to offer a place for innovators to work together on their own, to shape their own programs, because they represent leaders in industry as well. And this is a forum for them to share ideas. So next, the board of directors. So I think we've had a very important year for us, for CIDCI, and we've been hard at work at actually redefining and rethinking about CIDCI. So I would like to call out the names of our board members, and I would suggest that you can push, as I call your name, you can raise your name, you can push the space bar, and your tile will light up. But number one, Dean Reed, Howard Ashcraft, Jim Bedrick, Sig Rubel, Larry Hillman, Ian McLaren, Lynn Vitrone, Troy Thompson, Calvin Cam, So we also have had some outgoing board members, and these are important contributions that they have made to this organization. Renee Cheng, Chris Lukeman, who you will hear from me as well later in this whole presentation, Nikki Dennis Stevens with the AIA, and Eric Raft. All of these have all made significant contributions to the CIDCI, both in this last year and for many years actually prior. And we're very proud of their participation. So we are here. CIDCI is here. So we offer a newsletter. We offer free online webinars for our community of innovators. And also now, and we just want to make it clear, we really want to hear from you. This is our community. Innovation can only make a difference if we get together and really talk about our ideas and bring those ideas forward so that our owners, our builders, our designers can hear these ideas and start to adopt them, and that will in fact accelerate change. And CIDCI wants to be a catalyst for that. So we really do want to hear from you. And we'd like to hear, when we say that, we'd like to hear, so how would you accelerate innovation? How would you do that in this next year? So I would put forward this question to ask yourselves, and maybe put the response into the CIDCI. If only I could do what? That we would like you to think about that question. If only I could do what would that start to make you think in terms of innovation? So please let us know about how you're thinking about and how you're advancing innovation. So I'm going to move on now. So as I said, we are a community, and we can't be a community without you. So today, I would like to introduce Ray Tribino. And Ray is going to provide us with a video with some of his thoughts about innovation and CIDCI.
Thank you for allowing me to be part of this. CIDCI is a great organization that was envisioned several years ago by Stuart Ekblad, and it's so exciting to be part of something that was an idea that is now a reality here for the past several years. You know, this is a forum that allows us as industry leaders to get together and collaborate and innovate and think of what we can do to change our industry. You know, today we are in unprecedented times, and whatever we can do to come together and think of different ideas and ways to bring our skills and our ideas together to push forward to help our societies and our communities is something we all need to do. You know, these, as we all know, is unprecedented times we're dealing with, and this is not time to hold back. This is time to share and open up and really come and collaborate and really change what the world is going to look like in the future. So on behalf of DPR, again, thank you all very much for allowing us to be here. We're so glad to support this great organization, and we hope you all have a great forum. Take care and be safe.
Thank you very much, Ray. Those are very kind words, but I think really your passion around innovation, we want that to spread. So thank you very much, and really appreciate your continued participation and support of this organization. So today, our event sponsor is Convergent Technologies, and so we'd like to thank them as well. And this has been important about how that sponsorship has really helped us to move forward. Our list of sponsors has really grown, and it continues to grow. So there is another opportunity to become a sponsor. And we really, really appreciate that opportunity to do that. What do we want? We want to accelerate change. So in doing that, so we'd be happy to give each of you another opportunity to be a sponsor. So I also would invite you to contact us at CIDCI and join our community. What is going on about COVID-19? So certainly a huge emphasis on healthcare. And so the pandemic, as we all know, has caused all of us to make major changes in how we think, how we interact. For example, like washing hands, questionnaires, new apps, masks. These are all things that we now deal with every day. And I think, in some forms, they are innovations to respond to COVID-19, which we didn't have before, and we didn't have a need to invent in those sort of ways. So now I think we want to basically to talk about what are some of the changes now? What are some of the things we've changed in our physical environment as a result? For example, you know, are elevators going to become escalators? Are we going to limit the number of people that go in elevators? So on and so forth. So we would like to start looking at, so what do we think about as we move towards our new normal? So earlier this year, Ian McLaren basically, as a CIDCI board member, came up with an idea that, you know, we should really talk with some medical institutions in Northern California. We should hear what they're thinking about as owners, and what are they thinking about in terms of responding to the pandemic. So with that, I'm going to introduce Sandra Beck, and I'm honored. I've known Sandra for many, many years, but I'm honored to introduce her as a moderator for this session as we go forward for the rest of today. Sandra has over 40 years of experience in project delivery. She has been a leader both at UC Berkeley and UCSF San Francisco, and in their efforts and our efforts to develop IPD and lean methodologies. We'd now like to take advantage of what she's learned and her work now at UC campus in Davis. So I'd like to thank you, Sandra, for moderating this panel. And with that, I will turn it over to Sandra Beck. Thank you very much.
Thanks, Stuart. I'd like to briefly introduce today's panelists. James Pease is the Executive Director of Health Design and Construction at the University of California, San Francisco. James is also a board member of the Lean Construction Institute and is a California licensed general contractor. Joel Swift is our second panelist, and he is the Director of Facilities Planning and Development at UC Davis Health. Joel is responsible for major and minor capital projects from the planning end, design, through construction management, QA/QC, building official, and fire department capital program. And this includes $400 million in design and construction and over $1 billion in planning. He is also a licensed architect. I believe Joel will tell you that some of those numbers have been adjusted more recently. Pete Nocaresi is the Director of Construction for Northern California's Kaiser Permanente in their National Facilities Construction Division. Pete has been with Kaiser for about 1.5 years, and he has over 30 years of experience in the healthcare arena. And last but not least, Larry Kollerer, Executive Director of Project Delivery for Sutter Health. Larry has over 45 years of experience in facilities operations and in the design, construction, and commissioning of healthcare projects. So he sees them from beginning to end. He oversees a department that manages 450 projects annually, spending $600 to $700 million. Now, let's start today. Our objective in this conversation is to discuss two important topics. First today, how do we approach our work in the AEC industry with the advent of the COVID pandemic? What role has innovation played in this transition? My first question to the panelists would be, can you tell us how you reacted and what happened at your workplace in your domain on March 16th or 13th, whatever that date was, when our worlds shifted dramatically? James?
First of all, thank you, Sandra, and thank you, Stuart, Margie, and Monica for pulling this together, and all the CIDCI board members and sponsors. Yeah, that was a fun time. I think that I got a text message. I was over in Oakland, and we have a lot of Connex boxes in the ED parking lot. And it was, hey, can you have these Connex boxes out by this afternoon? We're starting to set up tents. And I had asked, is this serious? Or, it wasn't clear to me, and it was absolutely serious. So that kicked off really a 2-month whirlwind of projects. We ended up reopening the Mount Zion Hospital. We hadn't had inpatients there for 5 years. As happened to everybody else, our staff for our department went 100% remote, except for project managers working specifically on COVID related projects. We made a decision, myself and our team of directors, to stop all projects that didn't add capacity for COVID. So we thought it would be better to get people out of the hospital as much as possible if they didn't need to be there. In hindsight, it's hard to tell if that was the best decision. We spent a lot of time with our general counsel, understanding our contracts and what a potential stoppage of work would look like as far as of cost. And then since then, so my team has gone, all my direct reports, we now have a daily huddle, which we meet at 9:30 every day for a half hour and round robin, since we don't bump into each other in the office anymore. My boss and all his direct reports have a daily huddle, so there's a good way to escalate issues. And then I do a weekly, call it a sanity check with my team, where I just share anything that I've heard over the last week to try to keep people in the loop, since we're not cycling through the office. So I know my peers have a lot to share, so I'll stop there, but it's been a hectic time.
Thanks very much, James. Larry, how about you? Would you please share with us briefly how your world shifted?
Thank you. The initial hiccup of figuring out what to do, I think, happened to all of us. And we quickly realized that, in one view, all of our projects supported the COVID-19, and we went back to work. And remote, as James discovered, was a difficult thing at first. Sutter's teams are split up geographically throughout Northern California, so most of the teams pretty much dealt with this individually, and we only escalated where we had issues that seemed to address everyone. All of our projects largely continued. Interestingly enough, some of the hurdles that we experienced with our authorities having jurisdiction actually became simpler. especially as we brought projects online, especially where the projects supported direct patient care. What was, kind of a byproduct of this is coming up with systems to deal with things that needed instant attention that we felt, would require permits to do them and how to expedite those issues. I think Sutter has moved most of our projects into what we call the big room environment, especially the larger projects, and that was difficult at first to deal with and understand how we could communicate well with our teams. Interestingly enough, the projects that were in flight who had already developed those communications avenues worked very well. Where we had some issues is on projects that we were starting up and people really didn't know each other yet.
Thank you, Larry. That's quite an interesting point. I'm sure we'll talk more about it later. Pete, would you please give us your experience real quickly? Thank you.
Yeah. So, similar to James and Larry, we, got the bombshell dropped on us. And so we were quickly trying to figure out ways to create capacity in our buildings. We quickly started looking at shelved space, how we could convert that quickly, and how we can convert just normal offices or normal patient rooms to ICU rooms. We created what we call a playbook, and because Kaiser's in NorCal and SoCal, we shared between the two entities to try to do this. We, like Sutter, kept all our projects going. We felt that all our projects were essential and we weren't going to shut anything down. We looked at a parking garage that we had that we kept going because we figured, a parking garage can, once finished, can shelter tenants. One of the things we did, Kaiser's got a NorCal and SoCal community of practice with our preferred provider general contractors. And so we created a meeting place so that we could get everybody in there. And the topic was, how do you have virtual meetings? So we used the collective knowledge of all our trade partners and contractors to try to figure it out. I have a tagline that I use at Kaiser that says, none of us are as smart as all of us. And as you can see from the background of my house, I'm a Disney fanatic. I got that from a book about Disney magic. And it's really served us well, I think, we're really trying to bring everybody together to try to figure this out.
Thanks so much, Larry. Joel, how are you connected now?
This is a good test of resiliency. And I will say, this is not about bandwidth on the internet. It's about which cell service works at Lake Tahoe or not. And I won't give you names, but it just shows we have to be extra resilient. And actually, since March, I've been running 6 hotspots at our house and 2 cell services, and you have to toggle between them just to talk sometimes. So there you have it. But beyond that, we have a lot going on. We were caught in an interesting thing where basically we were getting mixed messages from the state, the governor, office of president, and unlike James at UC Davis, we're under a chancellor that's a general campus. So general campuses were shutting down. Our hospital leaders in Washington were saying we don't even need masks. So there's a dichotomy. But we took the approach that we were essential services. We had to deliver our 500 projects. So overnight, literally over a weekend, we switched to all virtual. We wrote a telework policy for our 60-odd employees, plus all of our CMs. And we basically have been running daily huddles since. So we went to extreme lean as a consequence of this. We had to convince contractors to show up at work. They were getting mixed messages. They didn't know if it was safe. But we took the approach that we were essential. It was important for us, delivering healthcare, our projects, our contractors, their livelihood of their employees, and the community, the economy. So it's been a real twist. It's been forcing us to change our practices for our design professionals. As Sandra knows, we were right in the middle of interviewing architects for the largest project we've ever conceived of, and we told all of them they were going to go all virtual for another 6 weeks of presentations. That was one project. Every other single project, small and large, literally had to convert overnight. So it's been a journey, and I think what the success is, one of our largest clients on the outpatient side told me last week that he was blown away that we've actually delivered more in the last 6 months than we've ever delivered in the last 6 years in terms of projects. So I think people have stretched and become better, and it's actually been a great opportunity.
Thanks so much, Joel. Just a little anecdote for you all around building team relationships with people you don't know on Zoom. I have to say, one of our architects interviewing had us take little breaks during the interview process, and one was the wave. We all had to do the wave of standing up and sitting down for a few minutes to move around, but also just got us all relaxing and laughing and starting to connect with people, because we're all still people, even though we're not together. So now we're going to move on to our second topic. We are all working in healthcare at a time when the public is focused on their health and those of their loved ones. So we know that we approach our work the same and somewhat differently because we feel that increased scrutiny. So how do we approach our work differently with the advent of the COVID pandemic? What role has innovation played in this transition? So Joel is going to get us started with a short presentation around a conversation, and then we'll go into discussions from each of the other members of the panel. Joel?
Thanks again, everybody. I appreciate the opportunity to be part of this forum. And I just truly think what CIDC is fantastic in terms of what are we doing about the technology, and the technology goes across such a spectrum. So I hope you find this compelling. This is just our story. I want to hear from everybody else too. But I started putting these slides together, and I feel like I came up with more questions than answers. So I want you to consider that. Think back 20 years, or maybe 10 years ago, or maybe January if you can't think that far back. In the healthcare profession world, we are right in the middle of so much acceleration of medical treatment. And frankly, all of this really starts with the individual, right? And so what I did is, on this picture, I pulled out some of the devices we are using in our house today. Some of them are probably very familiar, but 20 years ago, most of them weren't available to the public, or 10 years ago. Or some things really a lot of people didn't even know about in January. So the Internet of Things is really hitting us big time. If you look at this image, yes, that's a blood pressure cuff. That's for me because I got high blood pressure because of all this, my craziness at home. And there's that little blue thing in the middle, which is a pulse oximeter. Well, you know, those things used to be only available in hospitals. Those, you need them today. In fact, most of us should be checking our oxygen level. We certainly have one major elected official who's been having some issue with that. And that little tank of boost oxygen, well, back in the day when you were mountain climbing, you'd have to carry a big old tank, but those things weigh less than an ounce. I have someone in my house who runs very low on oxygen, and something we got to watch on. The last piece of this, if you look at that blue and green box, which looks like could have been a pager, that's my son's, that's his artificial pancreas. So essentially he has type 1 diabetes, and 20 years ago, the people with type 1 diabetes had to carry a lot of insulin around, a lot of needles around. And you know what, I hate to say it, but 30 years ago, someone would just die of that. It was called juvenile diabetes back then. Guess what? That's obsolete. He's getting it replaced by his next generation artificial pancreas, which is a picture of the one just underneath the PM 2.5, which is a closed loop system. All of this is literally pushing healthcare into the hands of the users. So, and oh, by the way, it was 999 PM 2.5 in my kitchen on Friday when I burned the pizza. So we're all experts. Purple air. Did anybody know about purple air before Campfire or before this year? Or do you know about it today? We live by it. We look for where we can have oxygen in where we live. So what does all this do to change the role of healthcare environments? That's sort of my big question for this. Oh, and by the way, you're going to get sick of my little scribbles. One of my inspirations was going to the DeYoung and seeing David Hockney's, and I'm no David Hockney, but his great exhibit, and he said, I'm relearning to draw on an iPad. And that's what I've been doing over the last 4 or 5 years. And I've been accused of having too loose of drawings by attorneys. So you'll see these scribbles because that's kind of visioning that I've been asked to do. So my new leader comes 2 years ago and he says, Joel, I want you to expand access in healthcare to all our communities. You're going to draw a circle 30 miles around Sacramento, which we know is the center of the universe. And I want to have facilities all along that perimeter on every highway that leads out of our city. You're going to develop a system for the continuum of care. It's going to be dynamic. It's going to be comprehensive. It's going to be a model to support this vision. And we were well into that. We are midstream in executing this major transformational change in what we're doing. Oh, and guess what? We had a couple fires. We had a pandemic. We've had to be resilient. So our model is flexing, and it's really looking at this continuum of care from the individual in their home, and what does that look like, to the community, outpatient clinics and hospital. A lot of this is already in place. Kaiser will say we've been doing this forever. And Sutter certainly has a great system. We're building a system because we really didn't have it. The next thing that came along in our world is we have a chancellor in Davis that said, well, I want to make Sacramento the urban campus. And I want it to be the anchor institution for the entire city and the region. And frankly, that's what they've done in Cleveland and St. Louis and Philadelphia and in Midtown Atlanta. So that continuum of care from the hospital and our cancer center, radiology, our outpatient clinics was already there. And what does that mean with all the telemedicine, health, and analytics and research? So we're injecting this anchor institution, which is our schools of health, and how that research plays back with industry partners, with our clinical trials clinics, which in our case is sometimes they're devices and sometimes they're treatments, and back to the hospital. So just a little bit about Sacramento, because I think it's worth noting, we are the youngest UC campus in the system. We're younger than, as a campus, as a educational campus, we're younger than Merced. Our first building was built 10 years ago. When I started in 2013, we opened the Telemedicine and Center for Virtual Care, which is essentially Davis's entry into rural health, which is a state-funded initiative to bring telemedicine to our entire state. Then we were fortunate enough to get a $100 million grant from Gordon and Betty Moore, and that's the same Moore of Moore's Law, by the way, and open a school of nursing. So we now have 2 schools. We actually have an actual campus. And today we're rolling out our new long-range plan and the framework that takes us in the future. So we were in the middle of all these projects. If you can imagine, when we're in motion and the pandemic hits, we've had to go back and talk with dozens of teams about what's changed. So we have sort of that continuum of a lot of development of how we're bringing ourselves forward, and everything from a new hospital that's breaking ground next month to the ice center that's under construction right now. We've had to go back to the teams, which is our folks who are providing the services and our design and construction teams, and saying, well, what's changed? What do we need to do different? How do we rethink these ships that are in flight? And of course, I have to talk about the hospital because that's the big engine. And we took this to our regents in June and July. We were very, very concerned that it was the largest project we embarked upon, smaller than Stewart's projects, but just around $2 billion. Their reaction was, it's too small. Your community needs more. We need more ICUs. Suddenly, our regents are experts on ICUs. They're also, I think as Stewart mentioned, experts on the sizes of elevators and how many people can be in an elevator. One of their questions was, do we need to double the number of elevators because of pandemic? Well, our Vice Chancellor, David Lebarsky, his response was very sage. And what he said was, we are building the hospital of the future. We have the opportunity to build the next generation of hospital. And we can talk about that. What does that look like? And replace the older generation. So we are evolving on the left-hand side of this diagram by tearing down what was built in the 1920s and 50s and building what's going to come up a century later. So pretty exciting. One of the things we looked at was, what does that do for our urban experience? And we're evolving into this wellness hub for our region and really becoming, and we're using that term, the Anchor Institute for Sacramento. And what that means is an anchor institution is essentially the meds and the eds, hospitals and higher education. And we're both for Sacramento. So along comes Aggie Square. This is our chancellor's vision of a partnership with private companies. And it's more than a vision. We immediately embarked upon transportation and acquiring a great team. Right away, Alice Waters, if you know Shapanese, she's bringing her institute to our campus. And that's for bringing healthy meals to school kids throughout the state of California. That's the vision. That's huge. That's way more than what we normally think of. And it's great food, by the way. So we're going from being a food desert to being a food theme park. Now, our other partners are Wexford Science and Technology, IBM, and of course, Cambridge Innovation Center. A lot of this rolls on top of healthcare, and it's bigger, but it's also about patient experience and access and community. And that also has really engaged us more with our communities around us than ever before. We're having great conversations with the city and the 5 or 6 neighborhoods around us, and their issues are about employment, gentrification. What does this do to the community? Are there opportunities? Are there problems? So we are really have a whole new vision of collaboration, and they've rolled into this too. This is going to be a big part of the future of our city. So anyway, Aggie Square, the diagram on the left really combines the hospital at the top and Aggie Square at the bottom, running through education. And our quote from our faculty is this: how do we rethink of this in the world of pandemic? And what this really means is this is going to be the place where collaboration happens. If everybody's going to be working remote in their home office, we need to have a place built that this is the best place to collaborate and build on everybody's diversity and abilities. So it's actually coming out stronger out of that conversation. So a lot of things changed. We were going to build a flat deck parking structure. This is just a little detail. We're getting ready to do what we call the wellness and mobility building. That got scratched completely because as a stress factor with all of our employees, our caregivers, they said, we need places to exercise, to a gym. We need collaboration and hoteling space. So we are flipping that into a sprung structure. Somewhere down the road, we'll still build that flat deck parking structure, but right now our priorities are shifted. That vision for the long term, the vision of the system, my little sketch on the left, is in action. We opened our Midtown clinic. We're opening Roseville this year. We're under construction, the Student Athletic Performance Center, and another clinic on the Davis campus, where, believe it or not, we've never had a UC Davis Health clinic on the Davis campus. And we're moving forward with smaller campus-like environments, facilities for our outlying areas. So the model is in the works, and our partnerships are shifting, and our needs are shifting, and I think we're going to be baking a lot of new ideas into each of the next projects. We've had to make modest shifts with our buildings right now, but it comes down to keeping them flexible. A couple last things. This is more to stir imagination. One of the things we're looking at is this rethinking the Todd. Everybody's sick of that. It's 30 whatever years old, but I've coined the phrase of a wellness-oriented development, and this builds on our Vice Chancellor's vision, and it also builds on another initiative that we just received some funding, donation funding for, which is healthy aging in a digital world. Let's say that again. Healthy aging in a digital world. I think that applies to all of us. So all these creative solutions of changing how people access healthcare, and the IoT that I started with, what is the broadband infrastructure, which, by the way, failed me this morning? What if I was on a heart monitor that had failed on? Don't know. What is resiliency? What is resiliency in terms of COVID and all the other things that have come on top of us? And then so there's some emerging questions. How do we integrate these new forms of telehealth into the community? How do we support all the aspects of the mind, body, spirit, and food and exercise? And how does this resiliency translate in the home when people are having to pick up and leave homes on a snap of a fire? So how does community fit into that? So this vision, this little scribbled Venn diagram, really looks at that continuum care from the house. And how do you have the home and the community common space, which is, a community zone that might have education, and notice how education is a big part of it. How does a hotel fit into it? How does health and wellness fit into it? How does your future hospital? That kind of translates into a very scribbled diagram of a transportation-oriented development that really is wellness-oriented. And we're working on this with a major senior builder right now so that we can integrate healthcare mission of, patient care, research, education, and community engagement. Oh, by the way, it's a fire-safe community that they suddenly flipped into. Rather than building golf courses, they're now concerned about resiliency in being fire-safe. So things have shifted even for developers. I'll throw out one last thing, because I got a call on a Friday saying by Monday my Vice Chancellor had to present to the Regents at home for 40,000 homeless people, and continuum care for another part of our population, the homeless population. How does what I just talked about for a senior community that people can afford to live in, how does that translate to our homeless populations? How do we address that aspect? What is their resiliency? I mean, they're the most fragile of our community in so many ways. So that, again, it's a question. Okay, I've gone pretty fast. I left with a lot of questions for the new normal, and I think there's a lot of aspects that the other panels can dive into or add to. But I think what I see is the new normal really is what's changing in the home environment. What are the regional services we're providing? How do we change those facilities? Are we hardening them? Are we moving them? Are we not building them? What does a community clinic even look like in the future? And that leads, of course, to what's decanted out of the hospital in the future and what does it look like? So I'm going to pause there. Thank you, everybody, and I hope this helps stir the conversation.
Thanks so much, Joel. We're going to go through the rest of the panelists now briefly, and then we will open it up for questions. Larry, would you mind chatting a bit on how COVID has impacted your world and your life in your job?
I think, as I mentioned before, our teams largely are working from home unless we have some of our PMs that are actually working at sites. Sites are much different than they were 6 months ago. So we spent a lot of time reorganizing our big rooms, and they're not near as crowded, and people are generally working from home. So our work continues. I think just sitting through this presentation, it was like drinking from a fire hose, and I think we all feel a little bit like that today, because we have a lot of experts that we work with that have all of a sudden come out of the woods and now tell us how to design mechanical systems, electrical systems, architecture, and so that has produced a whole bunch of work that has gone on in the background to adjust, listen, and learn and try to respond, because as we know, all of our buildings are unique, our systems are unique for each building, and the older the building, the more issues we have to deal with. So I think the teams have adapted to answer questions and deal with. I think we will see Sutter, beside, like Kaiser, has a lot of outpatient facilities as well as acute facilities, and our outpatient facilities generally had much simpler mechanical designs, where now our mechanical designs for these systems are probably going to be beefed up just for around the whole COVID issue and the transmission of the germs within the spaces and how to clean them, the materials we use. Generally speaking, our materials have been on the right track over the last decade. I think most of our institutions have gone to highly cleanable materials, and the challenge has been is to find those highly cleanable materials and at the same time not have them look like they're institutional in nature, and that's been our drive. So this has just put all of that more into issues that we need to be working on. Sutter will, those of us who are not in direct patient care will probably never return to an office full time. So we're busy studying how that's going to happen and how to have enough equipment at home to do Zoom calls and allow people to deal with these issues. So I don't want to use too much time. So why don't we move on to someone else's thoughts?
That's great. Thank you very much, Larry. James, will you tell us a little bit about how you approach your work with the advent of the COVID pandemic and what role innovation has played in this transition?
Yeah, so Joel kind of blew my mind there. Still trying to get my thoughts collected. And thanks, because I actually live in Rockland and Placer County, and so I can see the healthcare moving up towards my way. And so UCSF is very similar. UCSF has 4 graduate programs, no undergrad programs. And I would say it's very much in transition from being what 10 or 12 years ago was really a single hospital or 2 hospitals to now 4 full-blown inpatient hospitals and a growing outpatient network. And so how does UCSF live in a world with Sutter and Kaiser and also continue to advance research, education, and healthcare? So those are the 3 pillars of what UCSF is trying to do. So we're tasked with providing the space to do that. And in the short term, there's kind of in the short term and the long term. Stuart is really working on the long term and how you design a hospital of the future that you have to, as he's said a lot lately, you have to make design decisions now for a building that you can have in 10 years. And so a lot of that is probably just how do you build flexibility in, because what's it going to look like 10 years from now? I don't think any of us know. We can make some guesses, and some will be right and some will be completely wrong. At a more micro level, in just delivering small projects and renovations within our hospitals, there's very much a focus, as I know all the systems have, of getting our volume back. So a lot of people were just afraid to come to the hospital. They were afraid to go to the emergency department. As a father of 3, it's been great for me because the lines at the emergency room are much shorter. And I've been a number of times for cuts and sinus infections and things like that. And you can get right through. So if you need care, come to the ED. We are open. The surgical volumes have been coming back pretty fast, but there's a huge block of, we stopped doing procedures for 6 or 8 weeks, and then we ramped up relatively quick. So how do you get those patients back through? And so a lot of that is pushing more to the outpatient and making sure that we focus on really not trying to not do outpatient procedures in our inpatient environment so that we can maximize the inpatient environment. So we're working on opening, or really kind of cleaning up and reopening a surgery center that we have. And then Stuart's team is working to deliver a brand new surgery center that will be several years out. So as we bring on the ambulatory surgery, we can also increase the inpatient surgery. And then from a partnership point of view, the goal is to where we really feel like we excel is in the tertiary and quaternary care, and what we're calling complex care, where you have multiple comorbidities that you really need access to a wide range of super specialists. And so how do we partner with the community to have people get the care where they need it? So if we say partner with John Muir, and you live in the East Bay, and you can get that care at John Muir, but if you have something that is more complicated, then you have access to all of the research and the work done at UCSF. So that's where we are right now, is just blocking and tackling of getting our basic projects done and getting these things reopened, but also thinking about what do clinics of the future look like? What do waiting rooms of the future look like? As we were prepping for this call, it was mentioned, I think Larry mentioned, but UCSF saw the same thing. Over 10 years, telehealth looks like this. And then literally in one day, it goes straight off the screen. So I think that'll stay that way, which means we can see a lot more patients, as Joel said, where they're at in their homes. And so do we need as many exam rooms as we have now? What does an outpatient clinic look like in the future? I know there's also some work to change, like what the nurses can do with their licenses, because a lot of that is, do you really need to be seen if you have a sinus infection to get medication? Is that something you can do on a video visit? I know that'd be my personal preference. So I think healthcare is changing a lot, and maybe now changing faster than it's ever changed before. And we're just trying to keep up. I'll leave it there.
Thanks so much, James. Pete, last but not least at all, will you help us by digging in a little bit around construction and how COVID has impacted your world in construction and overseeing the construction, and as well as how innovation has helped you? Thank you.
Yeah, so, in the construction portion of it, construction has always been difficult with trying to figure out, since the pandemic, to figure out how to social distance, because there's lots of aspects of construction that, how do you social distance by hanging drywall, pouring concrete, and things like that. But, we've really struggled too, because the construction industry, we're going forward with our projects like James and Larry were talking about. But what does it hold in the future? Kaiser had basically over a $40 billion capital plan over the next 10 years. But now we have to figure out what we are going to build, and a big portion of the larger projects is all about collaboration, right? Big room, even if they're in construction, daily huddles for the trades is trying to figure out how we can space that out so that trades aren't close together during meeting times, but still being able to be heard with masks on. So again, I go back to that COP call. That was one of our big focuses is talking to them. Everybody's trying something out, right? PDCA, plan, do, check, act, adjust. We're really trying to look at our projects from that perspective, and me kind of being the construction liaison for all of Northern California, I'm going around to the different job sites and sharing innovations. One of the things that we really struggled with at the start was taking temperatures and getting people onto the construction sites, right? There was huge lines of construction workers, which is a productivity loss. One contractor came up with a thought of using a QR code with a form that gets filled out that answers all the questions that the county's required, and they could scan it with their cell phone while standing out there, so you're not waiting for each individual person to fill out a form. It downloads to a system that gathers all that. So, you know, it's using those innovative things to try to keep us moving, you know, and then as the rest, we're really struggling. What does an MOB look like in the future, right? How is telemedicine? We've looked at, you know, going back to the rural health days of, do we do our medicine in people's homes, right? Do we, I mean, Joel showed the diabetes monitor, you know, can we outfit people's homes with essential medical equipment devices that can be read from a doctor's office? You know, we've struggled with, in our MOBs, we had 2 providers per office, and now with COVID, is that the right thing? So we are kind of struggling with where we're going to move forward. But I think, again, innovation, collaboration, and everybody coming together, we'll get through this.
Thanks very much, Pete. Appreciate it. We have time now for a few questions.
Thank you all. This was so interesting. So we have a question here from Dakshan. Pardon me if I didn't say that correctly. As we move forward, how can we optimize technology without a disruption like a pandemic or disaster?
Larry, looks like you're getting ready to unmute yourself. Does that mean you're ready to weigh in on this question?
No, actually, I missed the question. I'm sorry. Someone was texting me, so I apologize.
That is one of the challenges of technology.
That is a
I'll
challenge.
jump in. Larry actually alluded to it with the question about how do we leverage technology. What I will say, and this owes a little bit of credit to Oshpod, is that our hospitals have the highest level of technology and resiliency and all the backbone infrastructure that you need. So our hospitals are really the best at it. In fact, I'm more concerned about the other levels as they step down, because our other facilities are more fragile. And when I say fragile, at least for University of California, we require 2 internet feeds, if you will, high-speed feeds to each location. The average house is lucky to have broadband. So that's one infrastructure that's a technology that much of the other technology totally relies on. So that will take some time and some efforts, and it's going to have some levels of, as we all know, failure. Then the other technologies are really being developed by these private companies, and a lot of those, as Pete said, historically, Kaiser and others went to the house. Well, now the technologies that are in the house, those are ripe to be leveraged, and I think we've all noted that telehealth skyrocketed, and now it's adjusting everything from your medical records to your other systems to make that work. And I think what I'm hearing is that we're all doing this right now, so it's in progress. It kind of had to happen overnight, and now it's maybe settling out and balancing. In terms of the built environment, we're now looking at how we improve the resiliency and the infrastructure all the way through the whole spectrum.
Thanks so much, Joel. I'd like to suggest we talk about telehealth a little bit. I think you raised a really good topic. And not only is working from home a big deal for so many people during COVID in terms of innovation, there's certainly innovation happening with telehealth. Many doctors felt uncomfortable, and people felt uncomfortable going to doctors, as someone mentioned. Certainly on my side, my partner needed shoulder surgery. How did we deal with that? You know, we ultimately went in for one visit, one in-person visit to actually have the outpatient surgery, but everything else was done from our home in Chico and from local imaging places where we were doing it all via telehealth. And this has been for multiple follow-ups and several prior appointments prior to going in for surgery. So obviously that's impacting our buildings, our need for offices, our need for bandwidth, our need for people to work from a telehealth system. I know someone mentioned to me recently, Joel, that UC Davis Health had gone, or someone said, was it James? Somebody, maybe Larry said you had gone from 600 to like 6,000 telehealth visits within a month or something. Would one of you weigh in on that and talk a little bit about how that's changed?
And I don't know if those are the exact numbers I use, but Sutter, I believe, went from 50 a day to 5,000 a day system-wide of telehealth visits, and that was done at a very fast pace. And interesting what I have found, because I have seen a doctor several times over the last 6 months for my wrists, and some doctors are very comfortable with this, and because I am 73 and spend a great deal of my time on computers, I'm pretty comfortable with it. My wife's mother, who is 96, not so comfortable with it. And so, it's a very interesting time, and I think we're all learning through experience as with our contractors we're dealing with. We have gone to virtual meetings with our contractors. The thing that we've learned is we now insist that they turn on the video, because if we require that the video be on, then we have attention, and generally you don't do what I just did, which was look at my cell phone and got distracted. But I think we've learned that sitting in a meeting with a huge bunch of contractors trying to work, and with our own staff, is we need the video turned on.
Maintaining focus in this world has been a big challenge for many of us. I personally thought I had a short attention span prior to COVID. Now, I really have to help myself focus. Can anyone talk about research and how space needs have changed in this area due to COVID? Has it been impacted? Yes? No?
I could just give a general statement. I don't know the exact numbers, but research is an interesting thing that our researchers have not been able to be remote, right? You have labs, you have microscopes, you have all this lab equipment. And so that's handled by my peer, Scott Muxon, but there's been a huge effort to the waves of getting the researchers back on campus. Because once everybody left the labs, the research stops in a sense. And so, there was dedicated research specifically to COVID, but now we got to get everything. We can't just stop. We got to get everything back up and going again. But maybe people can't be as close in the lab. Maybe you need to alternate when people are in the lab. But that does not seem to be something that you can do through Zoom.
Sandra, could I ask something really fast? Do you mind?
Sure.
So I'm just wondering, one of the things in any kind of innovation, there are things which work well, or any kind of change, things which work well, things which don't work well. You've heard some great examples right now, but I would wonder from you, what do you think is going to stick? What have you found to really be an advantage in this situation rather than a disadvantage that you'd say, gosh, I really hope that we continue to blank rather than go back to our old ways of blank? So this is really like an innovation journey, an unintentional innovation journey, for example.
So I guess one of the things we learned, I've heard from other folks as well, hybrid Zooms don't work, okay? You either all have to be in the same room together, or you need to have a mechanism where everybody's playing on a level field. So to that end, I think we've all for me, I've gotten a little tired of sticky exercises that everybody loves to do. Planners have been doing it for decades, lean people have been doing it for decades. I've found some great tools that can do that online, and are maybe a little bit more flexible. And if you really do have a dispersed team, which I think we all have, right? We're going to have, at least for several years, if not permanently. I think Larry's comment about, gee, his staff probably won't come back to office full time. Well, what does that mean? If all of your players say that, then you need to have a good mechanism for collaboration. So I think our collaboration tools are just starting to evolve and be more productive, frankly.
I'm in agreement with you on that, Joel. James, you want to weigh in?
Yeah, just one specific thing. We have a lot of people on our teams delivering projects that spend most of their time at a computer, say entering contracts in DocuSign or updating our project management platforms, and those are some of the lowest paid, which means they're not living in downtown San Francisco. They're living, many of us, even if it's 30 miles away in San Francisco, you're 2.5 hours each way into the city. And so I think we've started to think much more. We've shown that we can continue to operate. And so the question is, how do we maintain a culture? How do we train people, but not require them to commute 3, 4, 5 hours a day? The project managers, I find that they want to be in the office almost every day. They're working from home a little bit to get caught up. But everybody that I've informally had a meeting with that spends a lot of time at their desk has said that they love the telework and they'd like to continue. And if they only had to come in to a meeting once a week or once every other week, some way that we would maintain a team environment and a culture that I think that will stick. And across the organization in general, I mean, we've already exited a couple of leases where we've moved people into vacant space and gotten rid of some leases. And I think we're going to relook at our real estate footprint, but see, it's not really clear. When does this end, and does it stop immediately, or does it trail off? And I'm not quite sure what the future looks like, but I'm sure that it includes a lot more telework for a lot of people.
Thank you. I'd like to ask a question. Some of you had to hire large teams during COVID. Can you talk about how that process worked or didn't work with the teams? And also the next step, how did you form relationships with these people and with these teams to help you really make that final selection?
Yeah, we had quite a few virtual interviews and RFPs that went out. It was a little clunky at the start, you know, trying to figure out people not talking over one another. You know, we had some interview teams that thought it would be good for them to all get in one room and one camera, but you can't see their faces, and it's hard to read and get to know those people. So one of the things that came out of our COP of how to hold virtual meetings was that making sure that you have an icebreaker at the start. You know, I leave my background on because people found it very intriguing, the Disney. It gives you kind of a feeling of the people, right? Being able to see their intimate home, right? It helps, I think, build some of that. And, you know, just kind of the introductions a little bit. And then we, you know, we would set up a moderator on our side, and they'd have a moderator on their side for the questions, you know, because the raising the hand's a little difficult. So they, like you're doing, Sandra, fielding the questions and then asking your team. But it is a little more of a struggle, I feel, to really get the feel for the team, but it's getting better.
Thank you. Joel, James, Larry, anyone else like to weigh in on that topic?
Well, Sutter had a prohibition against Zoom, and Zoom is the most effective tool there is in my experience so far about having these meetings. So the prohibition has kind of gone away because through experience everybody discovered Zoom was the better tool. And I think as Pete pointed out, I think we'll see more and more, or maybe it was Joel, more and more of these tools come out over time, and I don't think we ever will return. I mean, I was driving 600 miles a week, so I don't miss 600 miles a week. And actually, I live in a good location because I'm kind of anti-commute no matter where I go or how I come home. And so my 600 miles were not near as bad as some of the people I work with who have 50-mile commutes that drive into downtown San Francisco from the East Bay, which is just horrendous commute. So I think, this will pretty much change for an awful lot of us forever. We've learned how to do some of this.
So I'd
Thank
add, I mean, the question also went to how do we build and maintain team continuity. So in our environment, I have a wide variety of fantastic project management folks to people barely clinging on to very simple projects. And some of them have just really, really struggled with it. And we found out that they literally relied on that eye-to-eye conversation with a contractor and an architect to get things done. So they have probably struggled more, which, by the way, have as much political ramification as big projects sometimes, as some of our larger, more adept folks. So I look at the more adept ones, and Sandra's on a team that we alluded to. We were doing a major RFP, and they were midstream and immediately converted to all virtual, but has maintained a hybrid component in a big room. And we're actually moving into a big room for that project because it's large enough and it warrants it. So we have the widespread. I do think that we're trying to coach everybody up. This is an opportunity, frankly, for me, for my mid-level supervisors to really step up and coach up their project managers and actually know better what they're doing, but also help them be better at what they do. And part of that is those different mechanisms of communications. Maybe it's a regular huddle, which we're big on in healthcare anyway. And if you do a huddle with your group and you make it effective and you make it short and you have a chance to talk to people, gee, that's a nice lean principle that we were trying to implement anyway. So we can leverage virtual meetings and lean together, in my mind, to get to some better results. And I do believe it's continually educating ourselves. And I will say, I talked about how we chose to be to lean towards the healthcare and not the education side. The UC education is Zoom. Healthcare is WebEx because it's more secure. And Zoom's had real problems. So we literally had two different tracks on daily basis. We jumped from Zoom to WebEx, WebEx to Zoom, still because of the politics internal of our massive organization.
I'd like to make one comment here. One of the questions is what specific software and collaboration tools are people using for large team collaboration and virtual working meetings? Definitely Zoom we have found to be best. I will say I've used Miro and Mural. I'm unconvinced yet which one is better. I haven't used them enough to learn. Turning the video on, a lot of things seem to be practical in my mind. You're doing things online, but being able to create that relationship with people and see them in the video seems to be really important. It's even more important to come to meetings prepared with an agenda and a facilitator, and for people to mute when they are not talking. Like having organized and meetings seems to become even more important than when we just got together in a room. At UC Davis Health, for our replacement hospital tower project, we're going to start using TouchPlan as a pull plan scheduling tool. And we're using this in the design phase to start. So we'll let you know how that works out. We evaluated a number of tools, and that was the most intuitive and easiest for everyone to learn. As I said, I'll let you know how that works out. Otherwise, I would say those are mostly the tools that I've been personally involved in. I haven't done Slack. We haven't really embraced Microsoft Teams so far, although some people do. I want to go to another question, please. I think it's a pretty good one. In the past, when a team would pursue the project, the client typically prefers team members to be quote unquote local versus pulling experience or expertise from a different part of the US. Now that COVID-19 has proven that proximity work can be done anywhere, will this change the selection or score when it comes to future projects post-COVID? Anyone care to weigh in on that one? I
think over time, COVID is going to hopefully be in our rear vision mirror. So, I think that is true. Once again, I think we've discovered if the teams that have worked together have much less issue to work remotely together. So teams that we have worked with that by and large have done other projects in a big room environment seem to get right up to speed very quickly. So this is kind of a long way to answer. I think it is much more difficult for expertise to be working across the country than occasionally coming to the site. So I think we will still remain to have a preference for local expertise over someone you have to pull in from the East Coast for a face-on meeting, which I think eventually we will get back to, is because, as James pointed, I think has been pointed out, right now we're living off our past and we're living off of the experiences and how people work together. I personally don't think you can develop that in a vacuum over video in the long run. So there needs to be some connection over time. So I think we will eventually return somewhat to some of the things we have done. Maybe not as extensively as we have done them.
I would say it also just relies on the scale and the scope of the project and the phase of the project. Generally speaking, general contractors who know our hospital are going to be much more effective and efficient than someone who's coming from far away, who's literally barely learning how to deal with us. However, some of those faraway teams do really well because they have that global expertise and they can negotiate their way through even construction issues like labor agreements. So again, scale and scope of project makes a big difference. I always say that we look at the best team, and there are local firms that are fantastic, and there are global, regional, national firms that are fantastic, but they have to come with the team that works the best for us. Sometimes that's a blend of knowing us and knowing the subject matter, and at the same time, there are some teams that have tripped because they know us too well, and maybe they take it for granted, or they might have some new people that they haven't brought in that know us. So it's a scale and scope. It's a project-by-project conversation.
Yeah, I'd like to add on, from the construction side, right, I'm looking at pool planning sessions. It's really hard to do a good pool planning session still virtually, because a lot of the usefulness of the pool planning is people being side by side, being able to banter back and forth and move their tags around. And we've created ways, we've used Bluebeam Studio, and you can have virtual tags, but I can't wait for the days to get back to the collaboration and people being able to be shoulder to shoulder next to one another talking, because as we can see on this, we all have to try to raise our hands, or one person has to be silent. You can't have kind of multiple people talking at the same time hearing it. So that I think is the downside.
Great. We have a question here from Colin Hughes. Although not all of you will go back to the workplace, some will. Your assets have been ticking over for 6 months or so. What are your concerns about when people start to return? How are you thinking about construction, design, materials, maintenance?
I guess from my point, we never left, and some people never were here. And that is to say that we've kept everything moving from purely the construction side, and really it's been a matter of our modifying our big rooms and maybe allowing more space or working with our clients a little differently. So it's been more of a twist on the projects that are in construction. I think there's a lot of people in my group that really want to get back their feet on the ground and how they have been working more remotely. And there's other people that have been working on campus this whole time. So what we're sorting through, it's a great question, is how you blend that. And it's been blending a little bit all along, and I don't think it starts or stops. I think it's going to continue to evolve. So I think it's really back to having our teams work together, train them up at the tools that they have, and look at the best team configuration for each of the projects.
We have a question here from Zig Rubel, who's on the board of directors of CIDCI. And I would like each of you to answer this question. What do you think the new next normal is for you? i.e., when do you think that change will stabilize so things feel more predictable?
I don't think there is one. I mean, it goes to the question about how do you keep innovating. I kept telling my team about the post-COVID world, and then finally I stopped saying, maybe there isn't really one. I mean, it's constantly evolving. there are kind of midterm and longer term, you know, I think even when people come back, we're looking at what does a hot desking scenario look like, which is used in tech, but it's, as far as I know, it's not really common to healthcare operations. You know, I think those tech workstations with everybody sitting across from each other, you know, that's probably out for a long time. But what does our office look like? I don't know. I don't know what will be next, but something will be next, and we will continue to change and adapt. And I think, if anything, that's the only thing we can rest assured on, is that there will be change in the future.
I would just echo James.
Oh,
Sutter is actually in the process of reducing our footprint for obviously where we do direct patient care, that footprint won't change, but we don't call it hot desking, but we call it hoteling, and we are basically looking at getting rid of about half of our office space over the next 2 years, and we are already in process and of depersonalizing the spaces, and not many people will have quote unquote an office. You will, and we're looking at applications where each individual can go online on their personal device and reserve a desk in a conference room, and depending upon what hub you're going to or need to go to, that is all done with an application, and there are applications out there to do that.
Larry, if I could follow up, do you have an idea of what you will do with this space? If you're, in other words, releasing all of this office space, do you have other plans for that space at this point? How are you thinking about that?
A lot of that space, whether if we lease it, we'll go back to the lease market, which is exactly what's happening in San Francisco as a whole. So we're looking at each of our spaces and looking at where we can consolidate, and some of the properties we own, which might mean we'll put them on the market. But generally our office space is not our clinical space. So it's a different building. It is a different building type.
Interesting. Okay, Pete, have we heard from you?
Yeah, I'd say that I'm like James. I don't know when we'll have a normal, but you know, I love history, and I always look back. I say, you know, the Spanish flu, which this has been compared to, right? We eventually, they social distance, they wore masks, they did all that stuff, but we eventually, I think, as human nature, we need that interaction, that physical interaction with people. I think we're going to go back, but I think there still will be a lot of this virtual things. I mean, I find it for my role in Kaiser, I have to drive around. I was having to drive around all of Northern California, but now I can attend more meetings. And I think meetings, if you're not required to be there in person, you can actually do more meetings because you can schedule them back to back. If I had this meeting from 8 to 9:30 here, and we were meeting, say, in downtown Sacramento, and then I had another one in Roseville, I couldn't be at that meeting in Roseville at 9:30. I'd have to skip it. Now I can be at those meetings. So I think it's creating that flexibility for us to be having back-to-back meetings, being actually more productive than when we were in offices.
Great. On behalf of CIDCI, I'd really like to thank Pete, James, Joel, Larry, and Sandra for being really an amazing panel. Your insights, your work, and frankly, your heroism at keeping hospitals open for everyone who needed them is something we're all deeply in your debt for. And with that, I'd like to turn it over to Chris Lupkeman for some closing remarks. Chris is a CIDCI board member. Please take it away, Chris.
Thank you very much, Margie, and hello everybody from Zurich, Switzerland. I'm glad to be the international outpost of our CIDCI group. It has been really fantastic. I've had the privilege of hosting similar conversations with colleagues here, not necessarily in healthcare, but in the industry and also in Asia. And what you're saying is right in line. What's fascinating to me is how you also differentiated between those who sit to work and those who stand to work. You know, we all here are very privileged to be able to sit, and there's a lot of our fellow citizens who had to sit, had to stand and continue to stand essential services, and to differentiate and understand how those different groups experience this COVID, right? Because many didn't have a choice as we did. The other thing that's quite interesting is, you know, humans forget. If we didn't forget, we would never fall in love twice, right? So when I think about this, and I think about how COVID and how this experience is going to roll through us, I can just pull into what you were just, what just saying, Pete, about how, you know, we will probably in many ways forget much of this. And that's why I'm always so curious about what we think is going to stick. And I think that's why I asked that question. I'm really curious about your answers. There's also the tools. I think some of the differences will be between the transactional and the creative, and I'd even go as far as the cultural, right? The transactional is far more efficient with Zoom or with Teams. The creative, we're still figuring it out, as you've indicated. And the cultural, I think, cannot be replaced, which we've all also described. Sitting down to have a meal together, or having tea or wine or whatever, that makes a lot. To be able to understand who that person is that you're sitting across from or sitting with. So I think that's actually quite fantastic. So we started off with Stuart telling us about some of the questions, and Margie telling us the questions. If only I could, if only we could, if only I knew about. I think this has been a really wonderful start to sharing the things that, oh, if I only knew what to do. And I think this is really fantastic to help. And also how, I can't remember, one of you said that you actually, part of your job was to go around as Pete. You say, I'm going around sharing best practices among your colleagues, among your job sites, in a way here on this Zoom, trying to help with each other share those best practices so we can also understand each other and do that better. And I think, Joel, you said you have more questions than answers. And I think this is a really great thing for us all to think about is, what are those questions which we now have? And what are the answers we wish we had? Because this is what CIDCI is really at its core about, is how we share best practices, how we share those questions, how we share ideas that might work in one place and not another, but we share it and we try that out. And I think this is really critical. We also started with, I think Larry, you might have said that, you know, change is constant. It's something I completely agree with. But one of the other things is how we wrap our heads around the big challenges of our time, but also the big challenges of our lives, whether it's climate change or the pandemic or the circular economy. This has to also be seen within, not without, but within the solution set for those evolutions as well. And I think this is a great thing for us to be able to stand in the mirror and look at ourselves and look at the young generations coming and saying, I did everything I could, you know, I made decisions which I know put us on the right path to finding those solutions and to making the world a better place. I also loved how you described the telehealth graph as being choo. I'm sure all of us wish we had some stock in whatever company would boom, because, you know, that would have made us all super happy. But I mean, maybe you did, I didn't, so who knows? But no, that's the great promise which we've been hearing. And I think that also brings up to my mind a conversation we've been having here in Switzerland is about the cybersecurity within health devices. Because this has been, I know that we have, our hospitals, one of our hospitals was held ransom by, right in the middle of COVID, actually right at the beginning of COVID. And it was, you know, very, very disconcerting. And so as we think about this critical, wonderful capability, which, you know, you're describing also your ring of bringing healthcare, distributing it, also how that distribution also creates vulnerabilities. And so how we have to weigh that and also be aware of it. I think this is a great thing, which all of you have been doing, is raising awareness of some of the issues which we need to be thinking more about. And finally, I would say I loved your questions about what will the waiting room look like in 2030? Sometimes I like to look at the waiting rooms of 1830 and wonder, you know, have they changed a whole lot? Well, yeah, okay, they have, but but yes, and what will a hospital look like? What will care be like? You know, how will we define this wellness-oriented design? I thought that was also quite wonderful. So I want to thank you very much for making the time to join us. We had over 100 and almost 120 people joining us today, and all of you who are here until the very bitter end. Especially want to thank again the panelists and Sandra for bringing us through this afternoon. This has been really wonderful. We will be back here tomorrow, same bat time, same bat channel. And make sure if you haven't registered, you can register. And we will be talking about data, changing how we work. 8 a.m. Pacific Daylight. And again, if you haven't registered, go to the CIDCI website to register. And we will look forward to seeing you there in another great group of panels. So we couldn't do this without our sponsors. Thank you again for all of those who have pushed up and put up to make this happen. Thank you very much. And to Stuart, Margie, and Monica. So with that, I'm going to wish all of you a very, very wonderful day. And it's time for me to go have a beer.
There you go. Thank you, everyone.